Question for Dr. Henry. When, if ever, is a CT scan with contrast indicated for a patient with headache?
Which scan again?
CT head.
CT brain with contrast. Is it ever indicated, and if so, when?
Let me tell you, there are little gangs in medicine which kind of get together and decide what they think ought to be done. There's a group that believes that if you've got somebody, you're suspecting a bleed, that sort of thing, plain film or the plain CT is normal, shoot the one with dye. If they cannot find a surgically correctable lesion of some kind on that, you don't have to do anything else. I'm not sure that that's actually the truth or not. Here's the problem. Here's the problem. If we did everybody in this room, 5% of you have an aneurysm of some kind. More than that, there are people, when they do the study, who have 5 or 6 small aneurysms. Which one do you fix? It's not a simple question, and by the way, whenever you get into this, and now the neuroradiologist got to take a look, and the neurosurgeon's got to take a look, 85% of the aneurysms are now treated by neuroradiology. They coil them. If I had a choice, that's the way I'd go. Which ones you do is a very difficult question. If you have a giant aneurysm, greater than 6 millimeters, those are the kind of things which neurosurgeons will go in. If they see it on that film, they'll go in and treat.
So that answers the question for CTA, CT angiogram. There are other times when you might get a contrast CT, but it depends on what's going on in your hospital. So sometimes you can't get an MRI right now, and you might pursue a regular old CT with contrast to look for things that you can't see. And there's also a CT venogram, which you can do, which is a contrast study when you can't get an MRI. So a CT venogram, for example, for cerebral venous thrombosis is about 90% sensitive, 85 to 90%. So if I don't have an MR available to me and that's what I'm worried about, then sure, I would. There are times, but they're really, I think the real message is it's on a really selective basis, and it also depends on what other imaging you got available to you at that moment.
Thank you.
Great. Over here on the left.
Yeah, I had a question about the use of Reglan and Compazine for migraines. I hear a lot of mixed opinions about whether it should be given IV or IM or PO, and I know there's some studies that say it should be given IV, but a lot of anecdotal reports that it works well orally. And then also I was wondering opinion on giving it with things like Benadryl or Toradol together when you're thinking someone comes in with a migraine and you're trying to treat them right away.
You know, there are probably as many treatments for migraine as there are people with migraine. Number one, I ask what's worked in the past. Number two, I still think that Compazine covers more of the symptom complex. It's not just the pain, it's the nausea. It's all the other stuff coming down the 5th cranial nerve. I still think that's the best way to go. The reason I tend to give IV is if I have to do rescue medication, then I've got an IV line in, and that's how it's going to be given. So there are arguments which way this ought to go, but I honestly believe that giving it to them IV looks more impressive. They think something has actually happened, and you can stop it.
Very good. Over here on the right.
You know, you also mentioned Toradol for migraines. Yeah, the literature on Toradol for migraines is basically, yes, bad. You know, some people love Toradol. You know, they give it for back pain, headaches, you name it, they give a shot of it. And I think that there's a certain reality about it that is not appreciated. Toradol is no stronger than 400 milligrams of PO Motrin. And the only reason that you would give Toradol actually is if you're going to give it IV for biliary colic or renal colic, right. And because they're, or uterine cramping. But the fact is that Toradol is grossly overutilized. It's a mediocre drug. It is Motrin ground up and shot in your butt.
All right, over here on the right.
How do you guys differentiate between vestibular neuritis versus BPPV?
I'll take it. I don't think there's a real importance in differentiating the two. They're both peripheral, so that's the first thing to understand. And so with a peripheral entity, your direction is to move toward symptom control no matter what. In terms of neuronitis, there are some people who have it as a consequence of a basilar skull fracture. I think that history is pretty self-explanatory. And then in those that have it as an infectious basis, you're looking for the infectious story that goes with it, either a current viral infection or in a post-viral period. As opposed to BPPV, which is really a sudden onset, I was completely well, and then I turned to back up the car and I threw up on the window. That kind of story is much more the BPPV story. So it's sudden, it's intense, it's episodic. Neuronitis, because they have a basilar skull fracture or an inflammatory process, is more persistent. In terms of determining specifically which one it is, though, it doesn't really matter because they're both peripheral and symptom controls where you're headed.
We drilled down on this in our board review course for the emergency physicians, and the diagnosis of the person who comes out of the car with the room spinning around, vomiting, and needs help getting out of the car, that's vestibular neuronitis. It is not labyrinthitis. Labyrinthitis is more of a infectious process kind of thing. Despite the fact that it's called vestibular neuronitis, people have no idea whether this is an itis or not. In fact, it may be some kind of vestibulopathy that is causing the issue. With regard to benign positional paroxysmal vertigo, typically those spells last 10 seconds. So the idea of a person coming to you for a spell that lasts 10 seconds is not going to be the case. They're generally older people. They have it recurrently, and they may come to you because they're annoyed of it, but nobody has 3 hours of the room spinning due to BPV.
By the way, I'd like to know what the panel's opinion is on the Epley maneuver. Is anybody here?
Say what?
The maneuver.
So the Epley maneuver.
Oh, Epley maneuver.
People say it
Epley.
works. There's papers that say it works. I still try it. I never get the results the papers say that you're going to cure a substantial number of patients doing it. I try it. I'm not as impressed with it as the literature suggests I should be. And every time another paper comes out saying how great it is, I try it some more, but I seem to be stuck in the either I'm not doing it right or something. I don't get the results. And
It's hard to do it right.
But I've paid careful attention to it. I don't know if anyone has other experience.
It's not just that it's hard to do it. If you Google the Epley maneuver, there's 10 different films doing it 10 different ways on the internet.
A lot of people's names have been associated to twists on this maneuver, the idea of trying to get these otoliths into a spot where they're not going to cause a delay in the movement of the fluid in the semicircular canal. He basically formed a little dam there that's kind of screwing up this movement. So you get dysynchronous movement in one ear versus the other ear in the semicircular canal, and that basically screws up your brain saying, I don't know where I am.
Thank you.
All righty, let's go over on the left here.
With respect to
Pull it down a little bit more. There we go.
Can you hear me now?
Yep.
With respect to lumbar punctures, side lying versus crouched over a Mayo stand, I've always been told that you can't get opening pressure with the upright one. Is that true? Or
Yes.
Well, go ahead.
Yeah, you shouldn't measure it while they're upright, but it doesn't mean that you can't get the needle in, keep the trocar in, and tilt them over onto their side and get the pressure then.
Okay.
So doing an upright LP, which I think we frequently do, because especially as we get obesified in this country, where it's harder and harder to do LPs, is you can certainly just get the needle in there with a trocar in and then just lay them on their side. I'm a big believer in opening pressures. It's amazing how often you find stuff that you wouldn't otherwise know. And you'll never diagnose people with idiopathic intracranial hypertension without it. So I'm a big believer in it, but you also have to get the LP in the first place. So.
Yeah, and by the way, I don't know whether it's the obesity in the country or whatever it is, but I did a lot more of them with patients sitting up. I looked at the anatomy of the individual patients. There were thin patients, laying them down on their side, not a problem. When I knew there was going to be difficulty localizing that spot, I think the sitting up position gets you where you want to be a lot faster.
Well, the other thing is a lot more of them are being done under the guidance of a radiologist, where somebody's got elderly, a lot of spurring, and you don't want to get a bloody
Well, that's
tap.
that's a different group of people, right?
Thank you.
All righty, over here.
I have a comment and a question. Because of the question about headaches, from my personal opinion, I've done a lot of Toradol, but it's always combination with an antiemetic, sometimes Benadryl, and I think everybody have their own cocktail. But you ask the patient, like Dr. Henry say, what works. But when I truly don't have drug seekers who are doing those type of things, I get great relief with Toradol. Or Anaprox if you're just trying to send them home.
It'd be great to do a study with here's 600 of ibuprofen, because even when Toradol's, unless it's given IV, the speed of Toradol by IM is no faster than Motrin orally.
Well, most of mine are IV, so I don't do IM because it hurts. My question is about using absorbable versus non-absorbable sutures. What places are the best places to use the absorbable so you don't have to have a revisit?
Scrotum.
It's also the age. So kids, with little kids, and this was discussed in the lecture, little kids are hard to remove stitches from. It can be almost as bad as putting them in.
Yep.
And so, the kid's got a little crusted scab over, 5 stitches. Now I got to pick the scabs off, find the knot, clip them. In that setting where there's a low risk of infection on the face, the ear, as was discussed, I think absorbable stitch is really appropriate to use in those, and then you don't have to worry about it. We're even doing it with some of our homeless people because, like Dye's Hospital, we have a lot of indigent care, and you see these people, they got a scalp lac, you put a few stitches or whatever into it, they don't come back. You see them 6 years later with a stitch dangling, a stitch or a staple hanging out of their head, and you're like, they just won't come back. And so we've gone to absorbable stitch for a lot of those too, because we know they won't follow.
You don't give them a staple remover to go?
Let me make a suggestion to you. If you are actually going to practice emergency medicine for a living, buy yourself a great set of lenses. As I grew older and older, it helped me tremendously to actually see what I was looking at. And I think removal of sutures on kids, things like that, know what you're looking at and not poking around without it. It just makes life a lot better. That was the most valuable tool I ever bought in my life.
Although there's a chronic mistake that many physicians make, or whoever sutures wounds, where they think that they are junior plastic surgeons, and they put the sutures on either side of the room about 1 millimeter or nanometer on either side of the wound.
Yeah.
So there is no loop. There is no loop of any consequence for anybody to find. And sometimes at our hospital, we took out all the stitches in our patients, and so we would have them come back, and you would be literally ripping out these loops of sutures because there's no way that you could find where the loop was. And so when that happens, there is a way to fix that. You basically say, I think these sutures could go for another 3 days.
Until that doctor's on.
Let's see when
that
Dr.
doctor's
So-and-so who put these ridiculous sutures in is coming back, and we'll never have this problem again.
I completely agree with what Rick just said about suturing of wounds. And when plastic surgeons look at our work in the emergency room, the common refrain is too many, too tight, too close. Right. That we put too many stitches in, we put them too close together in terms of the gap between from stitch to stitch, and we put them too tight, too close to the wound edge. The loop should be a more generous bite that's taken a millimeter or 2 further back from the wound edge. And if you just think about that, saying, I'm a broken record, I go look at residents who are repairing wounds, and I'm like, whoa, 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 too many, too close, too tight. And it's not uncommon for me to say that 10 times a week.
The other thing is there is this issue of once a wound has been sutured, that there is some reasonable effort that can be taken so that there is no crusting. You don't want to deal with crusting, removing it with scissors and trying to find the buried suture. So the idea here is, that they can get cleaned off with a Q-tip with some peroxide every day by mom, so that those crusts are removed. And the idea too is to always kind of keep some polysporin on it. Polysporin basically limits the crusting. accelerates the rate of wound healing in these kids. I mean, it's like it's no secret the literature is very positive about it. So there are some jobs for the parent to do to facilitate the removal of those stitches in 5 or 6 days.
Yep, absolutely.
All right, let's go over here on the left.
So I have a question about C-spine. I have never actually had a patient with a spinal fracture. Granted, I've only been doing this 2 years. But every single patient who comes in after getting hit in the parking lot or a minor MVC has terrible midline tenderness. So I'm wondering, do you have any tricks? You know, is there swelling? How can I tease out what is real midline tenderness, what is really possibly a fracture, versus, hey, I want my 10 Vicodin, can I go home now?
Well, the real test is to say something like, is that patient over there naked? And they go, like, then they get off the board.
No, I think I
That's not my
appreciate
experience.
I appreciate your dilemma, but really it is about focusing in really on the cervical spinous processes while you're palpating and trying to suss out, are they talking about pain on those points, the bony tenderness, midline bony tenderness versus paraspinous tenderness? It is confusing sometimes, and if you can't sort it out, then you're cornered with imaging. But I think that as you get a little better at this, and spend a little more time really focusing in on whether it's paraspinous, whether it's the trapezoids as they come up, you can separate them out.
I think this is where the Canadian rules have it all over Nexus. Where, I mean, if that's a mechanism, I got a little ding in the parking lot when somebody backed into my car and it dinged my bumper. They didn't hurt their cervical spine. I don't care how tender they are midline.
Yep.
So that's where I think the Canadian, I think you can kind of,
And we publish,
use
they're
one
in
or
your
the other.
handout.
I don't use both.
Okay.
But because you really can't blend them. But that's where the Canadian rules are great. And if you look at how many films Nexus and the Canadian rules prevent us from getting, it's really small. I mean, the problem is now it's CT scans that we're getting instead. But midline tenderness is one of the things. It's part of the problem. That and distracting injuries.
You know, my personal experience is actually that I don't find most people have midline tenderness. I guess it's a matter of the nuances, because the vast majority of people that we saw could be cleared clinically, because having them on that backboard is cruel and unusual punishment. And if they didn't have pain when they came in, by the time they've been on that backboard for a half an hour, they will have pain. And that's been shown actually in a study that was done of medical students or residents.
Residents,
Yeah,
I
residents.
talked about it, that a third of them would have pain for a couple of days after just an hour on the board.
Right.
So getting them off that board is a high priority.
All right, over here.
Question on foreign body. We said the batteries should be removed. What about the hearing aids which have the battery and the patient in just the hearing aid?
It's the battery against tissue. So if there's somebody who ingested a whole hearing aid, if a kid decided to swallow grandma's hearing aid, the battery needs to be out to be causing trouble, not in. So if there's something protecting it from the mucosa, it's fine.
It's okay.
It's the battery. It's the naked battery against mucosa that's the
Yeah,
problem.
if they chewed the hearing aid rather than just lick the hearing aid, I prefer to lick the hearing aid to get the wax off of it. Sometimes a child bites the hearing aid and then the battery's free, but yeah.
That's a $3,000 hearing aid that kid just swallowed.
You are fishing through the other
Bastard.
end in that kid. Get it back for here, Grandma.
Right.
One more
We're just
question.
going to wait till it comes out the other
Then
end.
grandma, if you retrieve it, gets an E. coli otitis.
One more question. This is about pneumonia with comorbidity, where we are treating it outpatient, and patient is allergic to fluoroquinolone. You said beta-lactam and macrolide was the alternate antibiotic. Which beta-lactam we are
One that has a
using?
broader spectrum, so something like cefuroxime, rather than something like Keflex. You want a second or third generation. Second generation.
Or cefapime, a lot of people are
a
using.
second generation, not a first.
Okay.
I think isn't cefapine a twice-a-day drug as well? Or
Cefapime is attractive for a lot of reasons. It's expensive stuff, though, make no bones about it.
Now, cefepime is intravenous, right? That's a
No,
intravenous.
there's an oral form.
There's an oral.
The oral?
Yeah, that's what we used for STDs until we can't use it anymore for that either.
I see. Is the dose same, like standard dose, or is it
Standard dose
higher
BID.
dose?
Standard dose BID.
Thank you.
All righty, over here on the left.
This question is for Dr. Bernbohr. I do have patients coming to me with bronchitis or chest cold, you call it, underlived cough for like a week or 10 days. They have taken dextromethorphan, guaifenesin. What is your recommendation? What do you think about Tessalon pearls?
I think if we could all just get together and figure out the magic phrase, we would all be wealthy. There is no magic for that. The reality, so part of the problem is people have soundbite expectations of illness. They expect to take a pill and have it be better in an hour. The reality is all of these coughing kind of illnesses last 2 weeks to as long as a month. And God forbid you got pertussis, you're going to cough for as long as 6 months.
It's called the 100-day cough, pertussis.
Right. So part of this is setting up expectations for patients, and it's miserable. And there's not a lot that's magic, and it's worth a little of this, try this, because they're miserable. But the reality is it doesn't. And I'll tell you, if they're there at the 10-day point, it's way too late for antibiotics at that point, unless they've changed clinically and they're febrile and have rales, et cetera.
And Diane told you.
Inhalers.
Yeah, Diane told you about the British study where they took dextro with the honey, dextro or honey without anything else. Without anything else did just as well. I have one did better. I have one for adults, and that is they now make a Jack Daniel's honey. So you put a little Jack Daniel's honey, squeeze of lemon.
Why adults? It makes your kids sleep. It's
Well, yeah, exactly. But Diane, you're going to have trouble when they talk about you giving liquor to the kids.
My mom
But
used
for
to let me sleep
adults,
with Jack
yeah, this is perfect. It's a great cough syrup for adults.
But cough, when we look at the literature on cough, I just, again, to say what I sort of shouted out, inhalers work better. So an albuterol inhaler and a steroid inhaler may do much more for their cough. And so when cough is the prominent symptom, I find the inhalers make a big difference.
Although it was kind of the idea of, okay, stop giving antibiotics and start giving out inhalers. And when that was looked at, there's only a small subset of the people who really get any benefit out of inhalers. And they basically have some clinical evidence of, very fine wheezes or some restriction. Yeah. But I think the biggest sin in this case, and this probably has already been covered, is to tell a person who comes in with a cold, well, if you're not any better, come back in a week, or who's coughing. Because when they come back, it's going to be expected. You're going to do something different than you did before, which means that you're going to give them antibiotics. And I think that we all need to be on the same page that this is a minimum of a 3-week illness, and there's really no cure for it. And stop giving, antibiotics for this thing, because it just reinforces the wrong message. It's a 3-week illness.
By the way, whatever antibiotic they get in the 3rd week, so they get amoxicillin for the 1st week and it doesn't get better, they go back. Then they're given Augmentin for the 2nd week and it doesn't get better. And so then they go back and they get cefepime for the 3rd week, and then the next time they get it, they come back and they say the cefepime worked.
Right.
It has nothing to do with it. It was just the 3rd week.
By the way, when you get out to 6 weeks in the coughing, I think there's more pertussis around than we thought of in the past. That's why I think it's reasonable to re-inoculate adults with pertussis. While they're there, we might as well give them the good stuff. But when you're out at 6 weeks, they're continuing to cough, I think it's reasonable to think about treating pertussis at that moment.
Oh, you can't treat it at that point.
By that time,
well, that's right.
there's no antibiotics going to work. You're just going to be miserable. I know I had it, and it is not like any other cough you've ever had. It's not like a bronchitis cough. It's one of these things where you feel your rectum is going to come right through the chair when you. Is that a little too graphic?
Yeah.
I personally thought it was accurate. I liked it. It was a good description.
I think the visual
I
was
looking
unnecessary.
underneath your chair.
We all looked under there.
I mean, you will have never coughed so hard in your entire life.
The other thing about chronic cough, if really somebody has 6 weeks or 8 weeks or 10 weeks of cough, if it's pertussis, it's one thing, but that's the time to look at the meds list. Are they on an ACE inhibitor? Or
Right.
that's the time to say, wow, you've been smoking for how long? Maybe it's time for us to do a few more things.
And also to consider asking the tuberculosis questions.
Right.
And in some areas, valley fever.
Yes.
Yeah, and we see quite a bit of valley fever in Los Angeles as well. So.
Thank you.
All right, over here.
Hi, I wanted to comment as well on the albuterol or the beta agonist prescription. They're expensive too, especially since they've all gone.
You know why they're expensive?
Because they just left the CFC, had to be refigured, and now there's no generics.
And the $10 albuterol inhaler is now $50 because it has a different propellant that they were required to put in. And so one of the benefits of that new propellant is now you can charge $50 and there is no albuterol inhaler generics anymore.
Which is tragic.
It's similar to the Colchris situation.
The what?
The colchicine now
Right.
is extremely expensive because only
It's-
Colchris is
Yeah,
available.
it's
that's
similar for
good.
the colchicine, except for there's almost no good reason to give colchicine.
Colchicine.
And there's lots of good reasons to give albuterol. So the fact that they made colchicine unavailable just means we preserved a bunch of people from getting renal failure and GI bleeds.
Diarrhea.
The fact that they made, and diarrhea, the fact they made albuterol unavailable by price is a problem. So they're similar with that caveat.
I did have a question, though, for Dr. Birnbauer. As far as the, you mentioned that the higher strength opioids other than codeine could help for the cough. And
The sub-analgesic dose.
right, but
opioids,
I
yeah.
found that the Tussian X, the chlorpheniramine plus the opiate, a lot of patients found a lot of benefit from that. And are you? And I know they're not making those combinations anymore. Do you use any of those? And if so,
I did.
which ones?
And I think part of the thing about all of this, there's literature which says none of it works, but then there's medical care, and there's the art of medicine at the bedside. And honestly, I have no problem with trying stuff when somebody's having a cough. The efficacy, the only thing that I've seen that really has proven efficacy is sub-analgesic doses of some of the opioids, non-codeine.
Which ones are you using?
I'm not. So I don't use those routinely.
Okay.
It's too expensive. I can't use it in my patient population.
By the way, for those of you who live and work in areas where it gets cold and we turn on the
Cold
furnaces,
reactive airway disease.
Yes, just understand there's lots of other things you might do. The cold steam vaporizer, which we give to all the kids.
I love vaporizers for this. I'm always,
Yes,
I
absolutely.
tell them it's part of grandma care. You get the chicken soup, you get the vaporizer out, you take the long hot shower and let the steam get in there.
Saltwater nose drops.
You do the saltwater nose drops, you do the gargles. I'm big on grandma care for this because I don't have much else.
At least
Exactly.
it'll keep you occupied till the thing's over with.
That's right.
Exactly.
All right, I think last question before lunch.
Yeah, Dr. Mellon, in the nail bed laceration repair, you mentioned less is more, but on the slide, it showed reattaching the nail plate. I've been to other suturing workshops at, like Sempa, for instance,
Yep.
where they have gotten away from that. I was just wondering if there's a consensus. Do you have to stick the nail plate back in?
No, I don't think you need to. There's lots of people talk about putting the nail plate and suturing it down at the base, knowing it's going to come off at the end. Lots of people have talked about another favorite tactic is to take the tin foil that your sutures come in.
I did
and
that
to,
for
and-
years.
And to make a little thing to bridge that underneath there to keep it adhesing down. All of the, and I'll grant you that the literature isn't fantastic on finger injuries, but there's quite a bit of it. So mostly when we're saying we don't like literature, it's because the methodology is not fantastic. But all of that literature says less is more. That you don't need to do these things. That when you manage these in a fairly conservative way, doing the minimal repair possible, that the outcomes are the same or better than when you go crazy.
They talked about the amputated fingertip and all of the literature that says you don't need to do anything. But then somebody would say, well, let's get to the plastic surgeon, and they do a VY-plasty, otherwise known as car payment. Those things come out the same. They really do.
Yep.
So don't reattach the nail plate.
I don't think you need to. I don't think it's hard and fast science regarding it, but I personally don't reattach the nail now. I did for years. I was a tinfoil converter. I was the tinfoil
We all
thing.
did
I was convinced that worked pretty well for a while with a lot of polysporin to slide it in under, and now I do none of it.
Well, that was worth the conference right there for me.
Great.
All right.
Thanks.
Thank you,
That was
guys.
it.
Have a good lunch.